Birth injuries represent a category of conditions that can cause significant anxiety for families, but understanding their nature and prognosis helps you provide appropriate reassurance while ensuring optimal care. Think of birth injuries as the mechanical consequences of the remarkable process that brings a baby through the birth canal. Occasionally, the forces involved in this natural process can exceed the tolerance of developing tissues, creating injury patterns that we can predict and manage effectively. The two main categories help organize your thinking about these injuries. Fractures occur when mechanical forces exceed the strength of developing bones, while neurologic injuries result from stretch or compression forces affecting the nervous system. This distinction proves clinically important because fractures typically heal completely with excellent long-term outcomes, while neurologic injuries may have more variable recovery patterns. Clavicular fractures stand out as the most common birth fracture because the clavicle represents the most vulnerable bone during the birth process. Picture the baby's shoulder navigating through the birth canal. The clavicle sits at the leading edge of the shoulder girdle, making it susceptible to the forces generated during delivery. Understanding the risk factors helps you anticipate which babies might be at higher risk. Macrosomia creates size mismatches between the baby and birth canal, while dystocia indicates difficult labor that generates increased forces. Instrumentation during delivery can concentrate forces in ways that increase injury risk. The encouraging aspect involves recognizing that most birth injuries heal without long-term sequelae, making early recognition and appropriate management the keys to optimal outcomes. Clavicular fractures during birth occur with a frequency that makes them part of routine neonatal care rather than rare events requiring specialized expertise. The incidence of 2 to 3 per 1,000 births means that every practitioner working with newborns will encounter these injuries regularly, making familiarity with their recognition and management essential for providing optimal care. Understanding why the clavicle becomes fractured helps you appreciate the mechanical forces involved in birth. Think about the anatomy of shoulder delivery. The baby's shoulders represent the widest part of the torso, and they must navigate through the maternal pelvis after the head has already passed through. The clavicle sits at the front edge of this shoulder girdle, making it vulnerable to the compressive and bending forces generated when the shoulder encounters resistance during delivery. Large infant size creates the most significant risk factor because it increases the likelihood of shoulder dystocia, where the baby's shoulders become impacted behind the maternal pubic bone. This mechanical impaction concentrates forces on the clavicle as the delivering practitioner works to free the shoulder. Interestingly, clavicular fractures can occur even with cesarean delivery, demonstrating that the injury sometimes results from positioning forces rather than just the mechanical trauma of vaginal delivery. The clinical challenge lies in recognizing that these fractures often go unrecognized initially because babies may not show obvious signs of distress. This explains why the excellent prognosis becomes such an important teaching point. Even when the diagnosis is delayed, the outcomes remain consistently good. The clinical presentation of clavicular fractures creates a pattern that becomes recognizable once you understand what to look for, though the signs can be subtle enough to miss if you're not systematically evaluating for them. Understanding these features helps you distinguish between normal newborn behavior and signs that suggest underlying injury. Decreased arm movement, sometimes called pseudoparalysis, occurs because moving the arm creates pain at the fracture site. Picture how you would naturally protect a broken bone by avoiding movements that cause discomfort. Babies demonstrate this same protective response by keeping the affected arm relatively still against their body. This decreased movement can be mistaken for neurological injury, which is why the term pseudoparalysis proves helpful in distinguishing mechanical guarding from actual nerve damage. The asymmetric Moro reflex provides another clue, because this primitive reflex requires bilateral arm extension and abduction. When one clavicle is fractured, the baby cannot fully extend that arm during the startle response, creating an obviously asymmetric pattern. Think of this as the baby's natural tendency to protect the injured side from painful movement. Crepitus over the clavicle occurs when you can feel or hear the bone fragments moving against each other, though this finding may be subtle in incomplete fractures. The palpable callus that develops at 7 to 10 days represents the body's healing response and often provides the first clear evidence of fracture in cases where the initial signs were missed. Perhaps most importantly, some clavicular fractures remain completely asymptomatic, discovered only when routine examination reveals the characteristic callus formation. This possibility underscores why systematic examination techniques prove essential for all newborns, regardless of their apparent comfort level. The management of clavicular fractures in newborns emphasizes the remarkable healing capacity of infant bones while providing appropriate comfort measures that support the natural recovery process. Understanding this approach helps you counsel families about what to expect while avoiding unnecessary interventions that don't improve outcomes. The technique of pinning the sleeve to the shirt for 7 to 10 days provides gentle immobilization that prevents excessive movement while allowing the baby to maintain normal positioning. Think of this as creating a natural sling that keeps the arm in a comfortable position without the complexity of formal immobilization devices. This method works because it provides just enough support to prevent painful movement while allowing the normal arm motion that promotes healthy development. Gentle handling becomes important during the healing phase because rough movement can cause pain and potentially disrupt the healing process. However, this doesn't mean the baby needs to be treated as if they're fragile. Normal feeding, diaper changes, and holding remain appropriate with just slightly more attention to smooth movements. The absence of special positioning requirements reflects the fact that the natural healing process works effectively without complex interventions. Unlike fractures in older children that might require precise alignment, neonatal clavicular fractures heal reliably through natural bone remodeling processes. The rapid healing with remodeling represents one of the remarkable aspects of neonatal bone healing. The abundant blood supply and active bone formation processes in newborns create healing rates that far exceed what we see in older children or adults. This explains why long-term complications essentially never occur, making this injury much less concerning than its dramatic name might suggest. When you encounter a newborn with decreased arm movement, developing a systematic approach to the differential diagnosis becomes essential because several distinct conditions can create similar clinical presentations. Understanding this differential helps you move beyond simply recognizing that something is wrong to identifying the specific cause, which fundamentally changes both your treatment approach and the prognosis you can offer families. Think of pseudoparalysis as a symptom rather than a diagnosis. It describes the observation that the baby isn't moving one arm normally, but it doesn't tell you why this is happening. To understand this concept, imagine encountering a child who is limping. The limp tells you something is wrong, but you need to determine whether it's caused by a fracture, infection, or another condition entirely. The same principle applies to pseudoparalysis in newborns. Clavicular fractures create pseudoparalysis through pain-mediated guarding, where the baby naturally avoids movements that cause discomfort. Humeral fractures, though less common, produce similar protective responses, but typically involve the upper arm bone rather than the collarbone. Brachial Plexus injuries result from stretch or compression damage to the nerve roots that control arm movement, creating true neurological deficits rather than mechanical guarding. Septic arthritis and osteomyelitis represent infectious causes that can create pseudoparalysis through pain and inflammation. These conditions require urgent recognition because delayed treatment can lead to permanent joint damage or chronic bone infection. The key clinical skill involves using your examination findings, history, and understanding of each condition's characteristic patterns to narrow the differential and pursue appropriate diagnostic studies that will lead to the correct diagnosis and optimal treatment. Congenital pseudarthrosis of the clavicle represents a fascinating example of how developmental anomalies can mimic traumatic injuries, creating diagnostic confusion that can lead to inappropriate treatment if not properly recognized. Understanding this condition requires grasping the fundamental difference between a fracture that fails to heal and a developmental failure that prevents normal bone formation in the first place. To help you understand this distinction, think about the difference between a bridge that collapses due to damage versus one that was never built completely in the first place. Congenital pseudarthrosis represents the latter scenario. During embryonic development, the clavicle fails to form as a single, continuous bone, leaving a gap that creates the appearance of a fracture that never healed. However, this gap was never actually fractured. It simply represents incomplete bone formation during the developmental process. The clinical pattern provides important diagnostic clues that help distinguish this condition from true fractures. The overwhelming right-sided predominance occurs because the right subclavian artery develops differently than the left, creating mechanical pressures during embryonic development that can interfere with normal clavicular formation. The fascinating exception involves dextrocardia, where the heart sits on the right side of the chest, which reverses the normal vascular anatomy and shifts the predisposition to the left clavicle. The absence of birth trauma history becomes a crucial historical finding because true clavicular fractures typically occur in association with difficult deliveries, large babies, or other mechanical factors. The painless prominence that parents notice represents the gap in the bone covered by soft tissue, creating a visible and palpable abnormality that doesn't cause discomfort because there's no actual injury or inflammation present. Humeral fractures during birth present a more complex diagnostic challenge than clavicular fractures because the anatomy of the developing shoulder creates unique obstacles to recognition. To understand why these injuries prove difficult to diagnose, you need to appreciate how the newborn shoulder differs from the adult anatomy you're familiar with from standard medical training. The proximal physeal separation represents the most common type of humeral birth injury, occurring when the growth plate between the humeral head and shaft becomes disrupted during delivery. Picture the developing humerus as consisting of two separate pieces, the rounded humeral head and the long shaft, connected by a cartilaginous growth plate that hasn't yet turned into solid bone. During difficult deliveries, the forces that pull on the baby's arm can separate these two components at this vulnerable junction. The mechanism mirrors that of clavicular fractures because both injuries result from the mechanical stresses generated when the baby's shoulders encounter resistance during delivery. However, the diagnostic challenge arises because the humeral head remains unossified in newborns, meaning it doesn't show up on standard X-rays. This creates a situation where you might suspect a fracture based on clinical findings, but the imaging appears normal because the injured part of the bone is still cartilaginous and invisible to conventional radiography. Understanding that ultrasound can visualize these cartilaginous structures provides a valuable diagnostic tool, while recognizing the excellent healing potential helps you counsel families about the typically favorable outcomes despite the initial diagnostic uncertainty. The clinical presentation of humeral fractures creates a pattern that helps you distinguish this injury from other causes of decreased arm movement in newborns. Learning to recognize these subtle differences becomes essential because the clinical examination often provides more diagnostic information than imaging studies in the immediate newborn period. Pseudoparalysis of the arm occurs for the same protective reasons we discussed with clavicular fractures. The baby naturally avoids movements that cause pain at the fracture site. However, the pattern differs slightly because humeral fractures typically create more global arm immobility, while clavicular fractures may allow some arm movement if the motions don't stress the collarbone significantly. Pain with passive motion provides a crucial diagnostic clue because it indicates that the problem lies within the shoulder region rather than representing a neurological injury. When you gently move the baby's arm through range of motion, the infant will typically cry or show signs of discomfort as the fracture site is stressed. This response helps differentiate mechanical injuries from brachial plexus injuries, where passive motion might be painless, but active movement remains absent. Swelling around the shoulder develops because the fracture creates bleeding and inflammation in the surrounding soft tissues. The muffled crepitus you might detect represents the bone fragments moving against each other, though this finding can be subtle and requires careful palpation to appreciate. The preservation of normal hand and wrist function provides an important clue that helps distinguish humeral fractures from brachial plexus injuries. When the fracture involves only the proximal humerus, the nerves controlling hand and wrist movement remain intact, allowing normal finger flexion and extension despite the proximal arm immobility. The imaging challenges associated with humeral fractures in newborns illustrate why clinical skills remain paramount in neonatal medicine, even in our era of advanced diagnostic technology. Understanding these imaging limitations helps you avoid the frustration of normal-appearing X-rays when your clinical suspicion remains high for fracture. Initial X-rays frequently appear normal because the proximal humeral epiphysis doesn't ossify until several months after birth. Think of this as trying to photograph something that's transparent to the camera. The fracture exists, but the standard imaging technique cannot visualize the injured structures. This creates a diagnostic dilemma where your clinical findings suggest injury, but the imaging doesn't confirm your suspicion. Ultrasound emerges as the most useful imaging modality because it can visualize the cartilaginous structures that remain invisible on X-rays. The ultrasound can show the separation at the growth plate and any associated hematoma or soft tissue swelling. However, this technique requires practitioners experienced in musculoskeletal ultrasound, which may not be available in all settings. The appearance of callus formation at 7 to 14 days provides retrospective confirmation of the diagnosis when the initial imaging was inconclusive. This delayed radiographic evidence represents the body's healing response as new bone forms around the fracture site. The timing of this callus formation becomes important because it typically appears slightly later than the callus seen with clavicular fractures. MRI rarely becomes necessary because the clinical course and eventual callus formation usually provide sufficient diagnostic information. The excellent healing potential of these injuries means that definitive tissue diagnosis through advanced imaging seldom changes management decisions or outcomes. The management approach for humeral fractures in newborns emphasizes gentle support while allowing the remarkable healing capacity of infant bones to restore normal anatomy and function. Understanding this conservative approach helps you counsel families about what to expect while avoiding unnecessary interventions that don't improve outcomes. Immobilization for 7 to 10 days provides adequate support for the initial healing phase without creating the complications associated with prolonged immobilization. Think of this time frame as allowing the acute inflammatory phase to resolve while the early stages of bone healing begin. The soft bandage or pinning the sleeve to the shirt creates gentle support that prevents excessive movement while allowing normal positioning and care activities. The rapid healing expected with these injuries reflects the abundant blood supply and active bone formation processes present in newborns. Unlike fractures in older children or adults, neonatal humeral fractures typically show evidence of healing within the first week and achieve solid union within several weeks. This accelerated healing timeline helps explain why the outcomes remain consistently excellent even when the diagnosis is delayed. The full remodeling potential represents one of the most remarkable aspects of neonatal bone healing. Even if the initial fracture creates some angular deformity or shortening, the active bone remodeling processes in growing infants can restore normal anatomy over time. This remodeling capacity far exceeds what we see in older children or adults, making anatomical perfection less critical for achieving excellent functional outcomes. Perhaps most importantly, growth disturbances essentially never occur with these injuries, meaning that the fractured arm will grow normally and achieve the same final length and function as the uninjured side. This reassuring outcome helps families understand that while the initial injury creates concern, the long-term prognosis remains excellent. Femoral fractures during birth represent a less common but mechanically understandable injury that occurs when the forces generated during delivery exceed the strength of the developing thigh bone. To help you grasp why these injuries develop, think about the mechanics of breech delivery, where the baby's legs and hips must navigate through the birth canal before the torso and head. This reverse delivery sequence creates unique mechanical stresses that can overwhelm the femur, particularly in vulnerable infants. The incidence of 0.13 per 1,000 births makes femoral fractures roughly 10 times less common than clavicular fractures, but the association with breech delivery creates a predictable pattern that helps you anticipate when these injuries might occur. Picture the mechanical forces involved when the delivering practitioner must manipulate the baby's legs and hips to facilitate delivery. These maneuvers can generate bending and rotational forces that exceed the femur's capacity to resist fracture. Understanding the risk factors helps you recognize which babies face increased vulnerability. Prematurity creates weaker bones that fracture more easily under normal delivery forces, while osteopenia represents a more generalized bone weakness that can result from various causes, including nutritional deficiencies or prolonged medication exposure. The encouraging aspect involves recognizing that despite the dramatic nature of a broken thigh bone in a newborn, the remarkable healing capacity of infant bones creates consistently excellent outcomes. The introduction of Pavlik harness treatment revolutionized the management of these injuries by providing a simple, effective method that maintains proper positioning while allowing normal care activities and promoting rapid healing. The management of femoral fractures in newborns illustrates how understanding infant anatomy and physiology can lead to treatment approaches that work with the baby's natural healing processes rather than against them. The Pavlik harness treatment represents an elegant solution that addresses multiple needs simultaneously while avoiding the complications associated with more complex immobilization methods. Think about why the Pavlik harness works so effectively for this injury. The device maintains the hip in flexion and abduction, which creates a stable mechanical environment for fracture healing while simultaneously preventing the muscle spasms that can displace fracture fragments. This positioning works because it relaxes the powerful muscles that attach to the femur, reducing the forces that might otherwise prevent proper healing. The practical advantages of harness treatment become apparent when you consider the alternative management options. Traditional methods like spica casting create significant challenges for families because they make diaper changes difficult and require special positioning for feeding and bathing. The Pavlik harness allows normal diaper changes because the straps can be temporarily loosened while maintaining the hip positioning necessary for fracture healing. The rapid healing timeline of 3 to 4 weeks reflects the remarkable bone formation capacity present in newborns. This accelerated healing occurs because infant bones have abundant blood supply and active bone-forming cells that can quickly bridge fracture gaps and restore structural integrity. Perhaps most importantly, the absence of long-term sequelae means that these dramatic-appearing injuries heal completely without affecting the child's future growth, development, or function. This reassuring outcome helps families understand that while the initial injury creates understandable concern, the long-term prognosis remains excellent. When you encounter a newborn with multiple fractures, this finding should immediately trigger a systematic evaluation for underlying conditions that predispose to fracture, rather than simply assuming that birth trauma explains all the injuries. Understanding this concept requires recognizing that while single fractures can reasonably result from the mechanical forces of delivery, multiple fractures suggest that the baby's bones are abnormally fragile due to an underlying condition. Think about this logically. If birth trauma were sufficient to cause multiple fractures, we would expect to see this pattern much more frequently given the mechanical forces involved in every delivery. The rarity of multiple birth fractures suggests that when they occur, something has made the baby's bones more susceptible to injury than normal. This reasoning leads us to consider osteogenesis imperfecta as the most likely underlying cause. Osteogenesis imperfecta represents a group of genetic disorders that affect collagen production, creating bones that are structurally weak and prone to fracture with minimal trauma. Types 2 and 3 present at birth with the most severe manifestations, making them the variants most likely to cause multiple fractures during delivery. To help you understand this condition, think of osteogenesis imperfecta as creating bones that have the same basic architecture as normal bones but are made from inferior materials, like building a house with the right design but using substandard materials. The associated clinical features provide important diagnostic clues that support this diagnosis. Blue sclerae occur because the abnormal collagen affects the eye structures, making the underlying blood vessels more visible through the thinner scleral tissue. The soft skull reflects the generalized bone weakness that affects all skeletal structures, not just the long bones. The presence of multiple healing fractures at different stages suggests ongoing bone fragility rather than a single traumatic event. Brachial plexus injuries represent one of the most complex and concerning types of birth trauma because they affect the intricate network of nerves that control all arm and hand function. To help you understand why these injuries develop and how they behave, think of the brachial plexus as the electrical wiring system that connects the spinal cord to the arm, carrying all the signals needed for movement, sensation, and reflexes. The incidence of 1 to 4 per 1,000 births makes these injuries common enough that you will encounter them regularly in your practice, but understanding their complexity requires appreciating how they differ fundamentally from the fractures we have discussed. While fractures represent mechanical failure of bone tissue that heals predictably, brachial plexus injuries involve damage to nervous tissue that has limited regenerative capacity and highly variable recovery patterns. The mechanism involves traction injury during delivery, where the forces generated by pulling on the baby's head and neck create stretch or tearing of the nerve roots that emerge from the cervical and upper thoracic spinal cord. Picture what happens when you pull on a bundle of electrical wires. Some might stretch and recover function, others might partially tear and recover incompletely, while the most severely injured ones might tear completely and never recover function. The spectrum of injury severity ranges from simple stretch injuries that recover completely within weeks to complete avulsion injuries where the nerve roots tear away from the spinal cord, creating permanent paralysis. Understanding this spectrum helps you approach each case with appropriate expectations while recognizing that the initial severity of symptoms does not always predict the final outcome. Understanding the risk factors for brachial plexus injuries helps you recognize the mechanical and anatomical circumstances that create the forces necessary to damage these nerve structures during delivery. Each risk factor contributes to the problem through slightly different mechanisms, but they all share the common theme of creating situations where excessive traction forces are applied to the baby's head and neck during the delivery process. Maternal diabetes creates larger babies through the complex metabolic effects of elevated blood sugar levels during pregnancy. Think of this as creating a size mismatch problem, where the baby's body becomes too large to pass easily through the birth canal. When the baby's head delivers normally, but the shoulders become stuck, the delivering practitioner must apply traction forces to the head and neck to free the impacted shoulders, creating the mechanism for brachial plexus injury. Macrosomia represents the end result of various factors that create oversized babies, with maternal diabetes being just one cause. The mechanical principle remains the same, regardless of why the baby is large. When the shoulders are wider than the pelvic outlet can accommodate easily, shoulder dystocia develops, requiring maneuvers that can injure the brachial plexus. Prolonged labor creates fatigue in both the mother and baby, often leading to situations where the normal mechanisms of delivery become less effective. This can result in the need for more forceful extraction maneuvers that increase the risk of traction injury. Instrumental delivery using forceps or vacuum extraction can concentrate forces in ways that increase the risk of nerve injury, particularly when these instruments are used to overcome shoulder dystocia. The important clinical teaching point involves recognizing that brachial plexus injuries can occur even with cesarean section, demonstrating that the injury sometimes results from positioning forces or extraction maneuvers rather than just the mechanical trauma of vaginal delivery. Understanding the anatomical organization of the brachial plexus provides the foundation for predicting which functions will be affected by injuries at different levels, and this knowledge becomes essential for both prognostic discussions with families and planning appropriate interventions. Think of the brachial plexus as a complex switching station where nerve signals from different spinal cord levels get reorganized and distributed to specific muscles and sensory areas throughout the arm. The upper nerve roots, specifically C5 and C6, carry the signals that control shoulder movement and elbow flexion. When you think about the muscles innervated by these roots, picture the deltoid muscle that lifts the arm away from the body, the biceps that flexes the elbow, and the various rotator cuff muscles that position the shoulder for functional activities. Injury to these roots creates the classic pattern where the baby cannot lift the arm or flex the elbow, but hand function remains intact. The middle root, C7, primarily controls elbow extension and wrist extension functions. Think of this as the nerve supply that allows you to straighten your arm and lift your wrist up. When C7 is injured in addition to C5 and C6, the baby loses the ability to extend the elbow and wrist, creating a more extensive pattern of weakness that significantly impacts functional recovery. The lower nerve roots, C8 and T1, control the intrinsic muscles of the hand that provide fine motor control and grip strength. These roots also carry the sympathetic nerve fibers that control pupil size and eyelid position on the affected side. When these lower roots are injured, the baby develops weakness in hand function and may show signs of Horner's syndrome with a constricted pupil and drooping eyelid. Understanding how the level of injury determines the pattern of weakness helps you communicate effectively with families about what to expect and guides your decisions about when to refer for specialized evaluation and potential surgical intervention. Erbs palsy represents the most common form of brachial plexus injury, accounting for approximately 90% of all cases, and understanding its characteristic presentation becomes essential for recognizing and managing these injuries effectively. To help you grasp why this particular pattern develops, think about the anatomical organization of the brachial plexus and how C5 and C6 nerve roots control specific muscle groups that create the baby's arm positioning. The classic waiter's tip position emerges because the injury affects the nerves that control shoulder abduction and external rotation, elbow flexion, and wrist extension, while sparing the nerves that control hand function. Picture a waiter holding his hand behind his back while waiting for a tip. The shoulder remains adducted and internally rotated because the deltoid and external rotator muscles cannot function properly. The elbow stays extended because the biceps muscle lacks innervation, while the forearm assumes a pronated position because the muscles that would normally supinate the forearm are paralyzed. The wrist flexion occurs because the extensors are affected, while the flexors remain intact, creating an imbalance that pulls the wrist downward. However, the fingers retain normal function because the intrinsic hand muscles receive their nerve supply from the lower nerve roots that remain uninjured in this pattern. This anatomical understanding helps you explain to families why their baby can move individual fingers and make a fist, but cannot lift the arm or bend the elbow. The preservation of hand function provides an important prognostic indicator because it suggests that the injury involves only the upper nerve roots, which typically have better recovery potential than injuries affecting the entire plexus. The clinical features of Erbs palsy create a distinctive pattern that helps you distinguish this condition from other causes of decreased arm movement while providing important prognostic information for families. Understanding why these specific findings develop requires thinking about how the normal reflexes depend on intact nerve pathways from the affected nerve roots. The absent Moro reflex on the affected side occurs because this primitive reflex requires the baby to extend and abduct both arms symmetrically in response to a startle stimulus. Since the C5 and C6 nerve roots control the shoulder abduction and arm extension needed for this response, damage to these roots prevents the normal reflex pattern on the injured side. When you elicit the Moro reflex, you will see the unaffected arm extend and abduct normally, while the affected arm remains motionless against the body. The preservation of normal hand grasp provides a crucial diagnostic finding that helps differentiate Erbs palsy from more extensive injuries. The grasp reflex depends on the intrinsic hand muscles that receive innervation from the lower nerve roots, which remain intact in this pattern of injury. This means that while the baby cannot lift the arm or bend the elbow, the hand will still close around your finger when you stimulate the palm. The asymmetric tonic neck reflex abnormality occurs because the normal response requires coordinated shoulder and elbow movements that become impossible when the upper nerve roots are damaged. The absence of Horner syndrome indicates that the sympathetic nerve fibers that travel with the T1 root remain intact, suggesting that the injury involves only the upper portion of the plexus. These clinical features combine to create the best prognosis among all types of brachial plexus injuries, because upper root injuries typically demonstrate better recovery potential than lower root or complete plexus involvement. Total plexus palsy represents the middle ground in terms of severity and prognosis, involving all nerve roots from C5 through T1, which creates complete paralysis of the entire arm from shoulder to fingertips. Understanding this condition requires appreciating how the loss of all brachial plexus function affects every aspect of arm movement and sensation, creating a clinical picture that differs dramatically from the partial patterns we see with isolated root injuries. The complete arm paralysis results from damage to all the nerve pathways that control voluntary movement throughout the upper extremity. Think of this as a complete electrical failure, where none of the signals from the spinal cord can reach their intended muscles. This creates a situation where the baby cannot move the shoulder, elbow, wrist, or fingers on the affected side, representing a devastating loss of function that affects all future arm use. The flaccid extremity develops because muscle tone depends on intact nerve connections between the spinal cord and the muscles. When all these connections are disrupted, the affected arm loses its normal muscle tone and hangs limply at the baby's side. This flaccidity differs from the normal relaxed state of uninjured muscles because it represents a complete absence of neural input rather than simply relaxed muscle activity. The absence of all reflexes on the affected side occurs because reflexes require intact nerve pathways to carry sensory information to the spinal cord and motor commands back to the muscles. With total plexus involvement, none of these pathways function properly, eliminating the Moro reflex, grasp reflex, and other primitive responses that would normally be present. The intermediate prognosis reflects the fact that while some nerve roots may recover function over time, the extensive nature of the injury makes complete recovery less likely than with isolated upper root injuries, but more likely than with complete root avulsion injuries. Klumpkes palsy represents the rarest form of brachial plexus injury, involving only the lower nerve roots, C8 and T1, and understanding this condition requires recognizing both its distinctive clinical features and its frequent relationship to recovery patterns from more extensive injuries. The rarity of this pattern as a primary injury reflects the anatomical mechanics of birth trauma, where the upper nerve roots typically bear the brunt of traction forces during delivery. The hand paralysis that characterizes this condition creates what we call a claw hand deformity, where the intrinsic muscles of the hand become paralyzed while the extrinsic muscles that bend the fingers remain functional. To help you visualize this pattern, imagine trying to use your hand when only the long muscles in your forearm work, but all the small muscles within the hand itself are paralyzed. This creates a characteristic positioning where the fingers assume a clawed appearance because the balance between intrinsic and extrinsic muscles becomes disrupted. The preservation of normal shoulder and elbow function provides an important diagnostic clue that helps distinguish Klumpkes palsy from other brachial plexus injury patterns. Unlike Erbs palsy, where the baby cannot lift the arm or bend the elbow, babies with Klumpkes palsy can perform all proximal arm movements normally, but cannot control their hand and finger movements effectively. The possible presence of Horner syndrome becomes diagnostically significant because the sympathetic nerve fibers that control pupil size and eyelid position travel with the T1 nerve root. When you see a baby with hand paralysis accompanied by a constricted pupil and drooping eyelid on the same side, this suggests T1 involvement and confirms the diagnosis of lower plexus injury. Perhaps most importantly, many cases of apparent Klumpkes palsy actually represent recovery patterns from total plexus injuries where the upper roots have regained function while the lower roots remain paralyzed. This clinical pearl helps explain why the prognosis for true Klumpkes palsy can be quite variable, depending on whether it represents a primary lower root injury or residual dysfunction from a more extensive initial injury. The associated findings that can accompany brachial plexus injuries provide crucial diagnostic information that helps you assess the severity of the injury and predict long-term outcomes. These findings represent damage to specific nerve branches that travel near the brachial plexus or share common anatomical pathways, and their presence indicates more extensive injury patterns that typically carry worse prognoses. Horner syndrome serves as a particularly important indicator because it suggests involvement of the T1 nerve root, which carries the sympathetic nerve fibers that control pupil size and eyelid position. When you observe a baby with brachial plexus injury who also has a constricted pupil and drooping eyelid on the affected side, this combination indicates that the injury extends to the lowest portion of the plexus. The presence of Horner syndrome often suggests that the nerve roots have been avulsed or torn away from the spinal cord, which represents the most severe form of injury with the worst prognosis for recovery. Elevated hemidiaphragm occurs when the phrenic nerve, which controls diaphragm function, becomes injured during the same traumatic event that damages the brachial plexus. The phrenic nerve arises from cervical nerve roots C3, C4, and C5, sharing a common origin with part of the brachial plexus. When you see a baby with brachial plexus injury and respiratory difficulties, or an elevated hemidiaphragm on chest X-ray, this suggests that the injury was severe enough to affect nerve structures beyond just the brachial plexus itself. Winged scapula develops when the long thoracic nerve, which controls the serratus anterior muscle, becomes damaged. This nerve normally keeps the shoulder blade flat against the chest wall, and when it's injured, the scapula protrudes outward in a wing-like fashion. The presence of winged scapula indicates that the injury was extensive enough to affect nerve branches that arise from the brachial plexus, suggesting more severe trauma that often correlates with root avulsion injuries. Understanding these associated findings helps you recognize the babies who need urgent specialist evaluation and those who may require early surgical intervention to optimize their functional outcomes. When evaluating babies with suspected brachial plexus injuries, understanding that your physical examination skills provide more valuable information than any imaging study becomes fundamental to proper management. Think of this evaluation as being similar to diagnosing a complex electrical problem in a house. While sophisticated testing equipment might exist, an experienced electrician can often identify the problem more accurately through careful observation and systematic testing of each circuit. Your physical examination should focus on systematically testing each nerve root function through specific muscle groups and reflexes. Begin by observing the baby's spontaneous movements, noting which joints move normally and which remain motionless. Then proceed to test specific functions like shoulder abduction, elbow flexion, wrist extension, and hand grasp. This methodical approach helps you map out exactly which nerve roots are functioning and which are injured. The importance of serial examinations cannot be overstated because nerve recovery occurs gradually over months, and documenting these changes provides crucial information about prognosis and treatment needs. Think of this as creating a movie rather than a snapshot. The pattern of recovery over time tells you much more about the injury's severity and the baby's potential for improvement than any single examination can provide. Understanding why EMG testing proves unhelpful in the acute phase requires recognizing that nerve conduction studies depend on electrical changes that develop weeks after injury. Attempting EMG evaluation in the immediate newborn period often provides misleading information because the electrical changes haven't yet developed, even in severely injured nerves. MRI becomes valuable for surgical planning when recovery plateaus or when you suspect root avulsion, but it doesn't change your initial management approach. The key principle involves focusing on functional recovery rather than anatomical perfection, recognizing that even partial nerve recovery can provide excellent functional outcomes when managed appropriately. Understanding the recovery patterns for brachial plexus injuries helps you provide accurate prognostic information to families while recognizing the important milestones that guide treatment decisions. Think of nerve recovery as being similar to a damaged telephone line gradually reestablishing connections. The process takes time, follows predictable patterns, and some connections recover better than others. The excellent prognosis for Erbs palsy, with 90% achieving full recovery, provides reassurance for the majority of families dealing with this condition. This high recovery rate reflects the fact that C5 and C6 nerve roots typically sustain stretch injuries rather than complete disruption, allowing the natural healing processes to restore function over time. However, understanding what we mean by full recovery requires recognizing that some babies may have subtle differences in strength or range of motion that don't significantly impact their daily activities. The proximal to distal recovery pattern follows the anatomical organization of nerve regeneration, where shoulder and elbow function typically returns before wrist and hand function. Picture this recovery as electrical power being restored to a neighborhood. The main lines get fixed first, then the smaller branches gradually come back online. This pattern helps you counsel families about what to expect and when to expect it. The return of biceps function by 1 month serves as a crucial prognostic indicator because it demonstrates that the nerve pathways controlling elbow flexion are recovering. Think of this as an early warning system. When you see the biceps beginning to work within the first month, it suggests that the injury was primarily a stretch injury rather than a complete disruption, indicating excellent potential for full recovery. While most recovery occurs within the first 3 months, improvement can continue for up to 2 years as the developing nervous system demonstrates remarkable plasticity. This extended timeline helps families understand that patience remains essential and that apparent plateaus in recovery don't necessarily indicate final outcomes. Learning to recognize the prognostic indicators for brachial plexus injuries enables you to provide families with realistic expectations while identifying babies who need aggressive intervention to optimize their outcomes. Think of these indicators as traffic signals that guide your clinical decision-making. Green light indicators suggest excellent outcomes with conservative management, while red light indicators warn you that surgical intervention may be necessary. The combination of Erbs palsy pattern with early biceps return represents the green light scenario, indicating the best possible prognosis. When you observe a baby with isolated C5-C6 involvement who begins showing biceps function within the first month, you can confidently predict that full recovery is likely with conservative management. This combination tells you that the injury involved primarily upper nerve roots, and that the damage was limited to stretch injury rather than complete disruption. Babies with total plexus involvement, but some early recovery fall into the intermediate category, where the outcome depends on how much function returns and how quickly it develops. Picture this as a yellow light situation where you need to monitor carefully and be prepared to intervene if recovery stalls. These babies often recover substantial function, but they may need surgical intervention if improvement plateaus. The poor prognosis indicators include absence of biceps function by 3 months or the presence of Horner syndrome. The 3-month biceps milestone becomes critical because it represents enough time for nerve regeneration to occur if the injury was recoverable. When biceps function fails to return by this time point, it suggests that the nerve damage was too severe for natural recovery. Horner syndrome indicates T1 involvement, which often correlates with root avulsion injuries that have minimal recovery potential. Complete avulsion represents the worst-case scenario where nerve roots have been torn away from the spinal cord, making natural recovery impossible. Understanding these prognostic categories helps you time your interventions appropriately and set realistic expectations for families facing this challenging condition. The early management of brachial plexus injuries requires a delicate balance between maintaining joint mobility and avoiding interventions that might interfere with nerve healing. Understanding this balance becomes crucial because while you want to prevent the secondary complications that can develop from prolonged immobility, you also need to respect the healing process and avoid causing additional injury to recovering nerve tissue. Gentle range of motion exercises form the foundation of early management because they prevent joint contractures while maintaining the flexibility needed for functional recovery when nerve function returns. Think of these exercises as keeping the mechanical parts of the system working properly while the electrical system repairs itself. However, the emphasis on gentleness cannot be overstated. You should move each joint through its normal range of motion in a slow, controlled manner that doesn't create pain or stress the healing nerve tissue. The instruction to avoid stretching distinguishes therapeutic range of motion from aggressive stretching techniques that might damage healing nerve fibers. Picture the difference between gently opening a door versus forcing it open. Therapeutic range of motion respects the natural limits of joint mobility, while aggressive stretching attempts to exceed these limits in ways that could harm the recovering nervous system. Supporting the arm when handling the baby prevents inadvertent traction forces that could re-injure healing nerve tissue. This means cradling the affected arm when lifting or moving the baby, rather than allowing it to hang freely where gravity or sudden movements might stress the brachial plexus. Think of this as treating the arm like a delicate piece of equipment that needs careful handling until it becomes fully functional again. The decision to avoid immobilization reflects our understanding that prolonged immobility creates joint contractures and muscle atrophy without providing any benefit for nerve healing. Physical therapy consultation ensures that families learn proper techniques for range of motion exercises while receiving guidance about activity modifications that support optimal recovery. Understanding when surgical intervention becomes necessary for brachial plexus injuries requires recognizing that the decision represents a balance between allowing adequate time for natural recovery and intervening before the window for successful reconstruction closes. Think of this timing as similar to deciding when to repair a damaged bridge. You want to give the structure time to demonstrate whether it can support traffic safely, but you can't wait so long that the damage becomes irreparable. The absence of biceps function by 3 to 6 months provides the most reliable indicator that surgical intervention should be considered. This time frame represents sufficient opportunity for nerve regeneration to occur if the injury was recoverable through natural healing processes. When biceps function fails to return within this period, it suggests that the nerve damage was too severe for spontaneous recovery, making surgical reconstruction the best option for achieving functional improvement. Documented root avulsion creates an absolute indication for surgical intervention because avulsed nerve roots cannot regenerate or recover function naturally. Think of this as a complete electrical disconnection that requires rewiring to restore function. When imaging studies or surgical exploration demonstrate that nerve roots have been torn away from the spinal cord, surgical reconstruction becomes the only option for achieving meaningful functional recovery. Recognizing when recovery has plateaued requires careful documentation of functional improvement over time. When a baby shows initial recovery, but then stops making progress for several months, this suggests that the natural healing process has reached its limits. In these situations, surgical intervention might help achieve additional functional gains that wouldn't occur with continued conservative management. The surgical techniques of microsurgery and nerve transfers represent sophisticated approaches that can restore function by rerouting nerve pathways or repairing damaged connections. These procedures often provide better functional outcomes than the natural history of severe injuries would predict, making them valuable options for carefully selected patients. Understanding that surgery can improve upon natural recovery helps you counsel families about the potential benefits of intervention when conservative management has reached its limits. When you encounter a baby whose head consistently tilts to one side with the chin rotated in the opposite direction, you're observing torticollis, a condition that requires systematic evaluation to distinguish between muscular and skeletal causes. Understanding this distinction becomes crucial because the two types have completely different treatment approaches and prognoses. Picture the mechanics of torticollis as an imbalance that pulls the head into an abnormal position. The head tilts toward the affected side because something on that side has become shortened or restricted, while the chin rotates away from the affected side as the baby attempts to maintain forward vision despite the head tilt. This positioning creates the characteristic appearance that makes torticollis recognizable across the room. While multiple etiologies can cause this presentation, muscular torticollis involving the sternocleidomastoid muscle represents the most common cause in newborns. However, the critical clinical skill involves ruling out skeletal causes because these require completely different management approaches. Think of your evaluation as determining whether the problem lies in the muscle system or the underlying bone structure, because this distinction fundamentally changes everything about how you approach treatment. The teaching point here emphasizes that not all torticollis is created equal. What appears to be a simple muscle problem might actually represent a complex spinal abnormality that won't respond to stretching exercises and might require surgical intervention. Muscular torticollis results from contracture of the sternocleidomastoid muscle, creating a mechanical restriction that prevents normal head positioning. To help you understand why this happens, think about what occurs when one of the two main muscles responsible for turning your head becomes shortened and tight. It pulls the head toward the affected side while limiting rotation away from that side. The palpable tumor that develops during the first few weeks provides an important diagnostic clue, though the term tumor can be misleading for families. This mass actually represents fibrosis and thickening within the sternocleidomastoid muscle, not a true tumor. Think of it as scar tissue that forms within the muscle, creating a firm cord-like structure that you can feel along the side of the neck. The association with hip dysplasia in approximately 10% of cases reflects shared risk factors, particularly intrauterine positioning constraints that can affect both the neck muscles and hip joint development simultaneously. This connection makes hip screening essential for babies with muscular torticollis, demonstrating how seemingly unrelated conditions can share common developmental origins. Plagiocephaly develops as a secondary consequence because the abnormal head positioning creates consistent pressure on one side of the skull during the period when the baby spends most of their time lying down. Picture how sleeping on the same side of the head night after night during the time when skull bones are soft and moldable would naturally create flattening on that side. While the exact cause remains debated, the birth trauma theory suggests that difficult deliveries or abnormal positioning during birth can create bleeding or inflammation within the sternocleidomastoid muscle, leading to the fibrosis and contracture that characterizes this condition. The management of muscular torticollis centers on stretching exercises that must be started early and performed consistently to achieve optimal outcomes. Think of the contracted sternocleidomastoid muscle as being similar to a rubber band that has been tied in a knot. The longer you wait to untie it, the more difficult it becomes to restore normal length and flexibility. Starting treatment before 3 months of age provides the best opportunity for success because infant tissues demonstrate remarkable plasticity during this period. The developing musculoskeletal system can remodel and adapt much more readily than mature tissues, making early intervention crucial for preventing permanent deformity. The specific exercise protocol involves 15 repetitions 4 times daily, focusing on 2 main movements: lateral flexion away from the affected side and rotation toward the affected side. Picture these exercises as gently coaxing the tight muscle to lengthen gradually over time rather than forcing it into position. The key lies in consistency and patience. Small amounts of stretching performed frequently work more effectively than aggressive stretching performed sporadically. Strategic crib positioning helps augment the formal exercise program by encouraging the baby to turn their head in the direction that stretches the tight muscle. Place interesting objects, mobiles, or the baby's preferred side for feeding on the side opposite the torticollis, creating natural incentives for the baby to work against the muscle contracture throughout the day. When conservative management fails to achieve adequate correction by 12 months of age, surgical release of the sternocleidomastoid muscle becomes necessary. This procedure involves dividing the tight muscle fibers to restore normal range of motion, though the results are generally better when the surgery is performed after conservative treatment has been attempted. Skeletal torticollis represents a fundamentally different condition, where the abnormal head positioning results from underlying bone abnormalities rather than muscle contractures. Understanding this distinction becomes crucial because the treatment approaches are completely different, and attempting to treat skeletal torticollis with stretching exercises proves not only ineffective but potentially harmful. Congenital vertebral anomalies create skeletal torticollis when abnormal bone development in the cervical spine prevents normal head positioning. Think of this as a structural problem where the building blocks of the neck are shaped incorrectly or fused together, making normal movement mechanically impossible. Unlike muscular torticollis, where the bones are normal but the muscles are tight, skeletal torticollis involves abnormal bone architecture that cannot be corrected through stretching. Klippel-Feil syndrome represents one of the most common causes of skeletal torticollis, where congenital fusion of cervical vertebrae creates the characteristic short neck and limited range of motion. Hemivertebrae, where only half of a vertebra develops properly, can create asymmetric growth patterns that force the head into abnormal positions. The requirement for spine imaging in suspected cases reflects the need to visualize the underlying bone structure to determine whether the torticollis has a skeletal cause. This imaging becomes essential because the clinical presentation can be identical between muscular and skeletal types, but the treatments are completely different. Perhaps most importantly, stretching exercises provide no benefit for skeletal torticollis because you cannot stretch bone abnormalities into normal position. Attempting aggressive stretching in these cases can potentially cause injury without providing any therapeutic benefit, making accurate diagnosis essential before beginning treatment. Several fundamental concepts about birth injuries deserve emphasis because they represent high-yield information that directly impacts your clinical decision-making and frequently appears on certification examinations. Understanding these key points helps you approach birth injuries systematically while recognizing the patterns that guide appropriate management. Clavicular fractures represent the most benign category of birth injuries, healing rapidly with excellent outcomes and no long-term complications. Think of these injuries as dramatic in appearance but minimal in significance. While they create understandable parental anxiety, the prognosis remains consistently excellent with simple supportive care. The critical teaching point about multiple fractures involves recognizing this pattern as a red flag that should immediately trigger evaluation for osteogenesis imperfecta, rather than assuming that birth trauma explains all the injuries. This distinction becomes crucial because the management approaches are completely different, and missing the underlying bone fragility condition can lead to inappropriate treatment and continued injury risk. Erbs palsy carries the best prognosis among brachial plexus injuries, with 90% of cases achieving full recovery through natural healing processes. This reassuring statistic helps you counsel families appropriately, while recognizing that the majority of these injuries resolve completely with conservative management. The absence of biceps function by 3 months serves as a critical prognostic indicator that suggests the need for surgical intervention. This milestone represents sufficient time for nerve regeneration to occur if the injury was recoverable, making it a reliable decision point for determining when more aggressive treatment becomes necessary. Finally, the importance of differentiating muscular from skeletal torticollis cannot be overstated because the treatment approaches are completely different. Muscular torticollis responds well to stretching exercises, while skeletal torticollis requires recognition of underlying bone abnormalities that cannot be corrected through conservative measures.